Welcome back to this channel, and if you are new here, I am René Serbon, skin expert and educator, helping professionals build real skin knowledge grounded in sound skin science. One of the most common clinical mistakes I see even amongst experienced practitioners is confusing acne with rosacea. Now, on the surface, they look very similar. Both involve redness, both can be present with pustules, both are inflammatory, but they are not the same condition, and treating them as if they are is one of the fastest way to end up with protocols that just don't work. Today, I want to walk you through what acne and rosacea have in common, what fundamentally separates them, and how to assess severity so that you can differentiate between them with confidence in your practice. So let's start with the similarities because this is where most of the confusion comes from. Both acne and rosacea involve inflammation. Both can present with redness, both have pustules, and in many cases, they both can compromise the skin barrier. When you're looking quickly at the skin or when a client describes their symptoms too vaguely, it's easy to lump the two together. But clinical assessment isn't about surface pattern recognition, it's about understanding what system is actually involved with these conditions. Now, acne is at the core a follicular condition. It involves the pilosebaceous unit, excess sebum production, follicular pluggings, bacterial colonization, and inflammation. The sebaceous gland is actually central to the pathology, and when you're assessing acne, you're looking for follicular involvement, comedones, oil production, congestion, and lesions that are centered around follicles. Rosacea, on the other hand, is a completely different story. Rosacea is a vascular and neurogenic condition. It involves vascular instability, neurogenic inflammation, and often an altered immune response. The sebaceous gland is not the primary driver here. Clinically, this shows up very differently: diffuse redness rather than follicular congestion, flushing, visible blood vessels, and pustules that are not centered on follicles. As a real-world example, one of my clients came in saying that she had adult acne. She did have redness, she did have pustules. But when I assessed her properly, a few things stood out immediately. There were no comedones. Her skin wasn't oily, it was actually quite dry and reactive, and the redness was diffused rather than follicular. And so when she mentioned that her skin flared after stress, heat, and hot drinks, it was a clue to me that this was not acne, that it was rosacea. Now, had we treated her skin with traditional acne protocols, we would have made her condition significantly worse. Another clinical piece of assessment is severity of both conditions. Acne is typically graded as mild, moderate, or severe based on the lesion type, the quantity of the lesions, and the scarring risk. Rosacea is also graded by severity: mild flushing, moderate persistent erythema, with pustules, and more severe presentations that can include thickened skin or ocular involvement. Now, severity matters because it determines how intensive or conservative your approach should be in your treatment protocol, and if it actually fits within your scope of practice. A mild case does not need the same protocols as a severe one, regardless of the condition. So here's an important distinction that often gets missed. In acne, barrier compromise is often secondary. It's frequently the result of aggressive overtreatment, overexfoliation, or harsh actives. In rosacea, barrier compromise is often the primary factor. The condition itself disrupts the barrier, which is why these clients are so reactive from the very start. This changes everything about the sequencing. With rosacea, barrier repair isn't optional at all. It is actually foundational. So how do you differentiate acne from rosacea when in practice? We start with a few key questions and observations. Are there comedones present? Is the redness diffuse or follicular? What triggers flares? Hormones and congestion or heat and stress? Is the barrier compromised from the outset or are there visible blood vessels? When you layer these observations together, the diagnosis becomes much clearer. Acne and rosacea may look similar at first glance, but they are fundamentally different conditions. Differentiating between them accurately is what separates guessing from clinical reasoning, and it all comes back to assessment. This kind of clinical thinking is exactly what we teach inside the Professional Skin Assessment Mastery. If you're ready to move beyond surface level analysis and start assessing with confidence, the link is in the description below. Thank you guys so much for watching. Please like, subscribe, and share, and I will see you next week.